So there's this scene from the movie Men in Black where this guy's brain opens up or his head opens up, and there's this little alien sitting with the controls, and he's making all the moves. And it reminds me of us taking over ventilation in a patient that has a metabolic acidosis, whether that be minor, severe, whether it's lactate that's elevated, or something like ketones, beta-hydroxybutyrate. And it reminds me of the daunting task of having to make those decisions. You are the clinician with this severe metabolic acidosis, and now they're intubated, right? And even though that's not preferable, we know that sometimes these patients do end up getting intubated, whether it's from fatigue, they're not compensating. And you have to have a plan. You have to have the ability to compensate for them. And it really boils down to two different strategies. And so there's like the offense strategy, which is fixing the issue, right? If they're in an acidosis because they have sepsis, then we need to fix the sepsis, source control, antibiotics, etc. If they are in a metabolic acidosis because of something like a DKA, diabetic ketoacidosis, then they need insulin. So that's the offense strategy. But just as important is the defense strategy. And that is not letting the problem get worse, or not making the problem worse. And so to understand this, what I want to do is get into the core principles of acid-base, but it's probably unlike any other way you've heard it explained. And I promise, even though acid-base can seem very challenging, a little bit intimidating, I'm going to break it down to some core concepts that is going to make everything else we talk about completely click and make sense. And I'm going to start off by showing you what happens when you throw a pound of sodium metal in the river. So we'll let this guy throw this in here. He's just throwing a pound of sodium in the river, and this is how we're introducing acid base. So he throws it in there, and what he's going to get is this exothermic reaction. Because that has a charge to it. It is, sodium is a positively charged ion. And so in order to try to balance out, what it essentially does is causes this explosion because it hits water. And so it's trying to steal those negative ions from the water, and it creates this reaction, right? And so the central concept of all of this is electrical neutrality. You have to have equal parts positive and negative. And so when I show you this is called a Gamblegram. This really puts it into perspective. So our body is made up of different types of electrolytes, different compounds, molecules, and they all carry a charge, whether that be a positive charge or a negative charge. And they have to be equal. You ever notice, like when you give somebody sodium or normal saline, it's sodium chloride, or it's potassium chloride, or sodium bicarbonate. You're always giving a positively charged ion with a negatively charged ion. And so the reason this is important is because the body will do whatever it takes to maintain this electrical neutrality. So I want you to imagine that we add something over to the negatively charged ions, right? These are called anions. We're going to add something over here. And what we're going to add is an acid. We're going to add something like beta-hydroxybutyrate, which is one of the ketones that gets produced when the body can't burn sugar, and so it has to burn free fatty acids. Now, if I add something in over here, that would now make this column bigger, right? We wouldn't be level. So that means that either I need to add something over here as well, or I got to get rid of something on this side. And the easiest thing for the body to get rid of is bicarb. So I'm going to add in my ketones right here. So you see, I added something in here. Now, the bicarb has to shrink in order to make room for these ketones. So what does this look like at the clinical level? Well, you get a patient who is in DKA, and you look and their bicarb is low. Normal bicarb somewhere between 22 to 26, and you look and their bicarb is 10. Well, that shows you the degree that the bicarb had to shrink in order to make room for the ketones. So would it make sense to go in and give this patient bicarb? No, the body would be like, no, you big idiot. I just got rid of this to make room. And so this is so fundamental to understanding why bicarbonate is not useful in some situations. Now, if you gave this patient insulin, what would end up happening? Well, the insulin would allow the glucose to go into the cells. We wouldn't have to create ketones anymore. The ketone load on the anion column would start to shrink, and then the bicarb would just come right back to normal. That's what you'll hear people refer to as like closing the gap in DKA. And so I use ketones here, but if you increase the lactate, if somebody's in septic shock and they got an elevated lactate, or they have an ischemic gut and the lactate starts to elevate, well, we got to get rid of something over here because something is growing, and so we end up getting rid of bicarbonate. What about chloride? Well, if you give somebody normal saline, the 0.9% saline, it's 154 milliequivalents of sodium and 154 milliequivalents of chloride. That's way more chloride than we normally have. So what's going to end up happening? You're going to see that bicarb start to shrink again. It creates a hyperchloremic acidosis. So when we talk about bicarb being a buffer, it is a buffer. It's buffering out this area to make sure that we can maintain electrical neutrality. And so how far the bicarb has to shrink in order to make room for whatever's being added or whatever's growing gives us an idea of the severity of that acidosis. And you can put it on something of a spectrum like this, where oxygenation perfusion issues, if somebody's having a really bad asthma attack, or somebody's hypotensive from sepsis and their lactate starts to increase, then that will cause a metabolic acidosis. But you don't see it as severe. You don't see the bicarb have to shrink as much as it does with like a Tylenol overdose, an aspirin overdose, DKA. All of those things cause more of a drop in bicarb because they're taking up more area in that anion column. And so here's my bicarb levels, and these kind of just outline the severity of how low the bicarb drops represents how much of that acid is being added and occupying the anion side. And while you may think of acid as the hydrogen ion, H plus as being positive, the conjugate base of that, the thing it's mixed with, takes up quite a lot of room on the anion side. And so that's why we start to see the bicarb shrink to make room for whatever's being added over there that's occupying that space in the anion column. Now, when we shrink bicarb, when we get rid of it, it gets dissociated and turned into CO2 and water. And so now we have elevated levels of CO2 in the plasma. Well, why is that an issue? Well, let's look at these two things, right? So the water, not a big issue. But the CO2 is a bigger issue because in a setting like DKA, where you have ketones that are now floating around and you have CO2, the body does not like free CO2 floating around in the plasma. It keeps the CO2 that's just in its gas form inside the plasma very, very controlled. The majority of CO2 is transported actually as bicarb. So if we're shrinking the bicarb, well, now we don't have anything to transport that CO2. And free CO2 floating around in its gas form, what you see when you measure like a PaCO2, that causes the acid base disturbance to start leaning more on the side of being in an acidotic state. So this is a cool form. Or a cool graph. I like how this is laid out. And so what you can see is that the majority of CO2 is transported as bicarbonate. The actual dissolved gas CO2 is very, very small. But when we shrink the bicarb, we increase the amount of dissolved gas CO2. And so what does this do? It drops our pH. It makes us become more acidotic. This is the reason why patients get that small respirations in a severe metabolic acidosis. It's because not only do they have to blow off the CO2, but they got to get these CO2 levels down so low because they don't have the vehicles to transport it. They don't have the bicarbonate to transport that CO2. And so what ends up happening is the dissolved gas CO2 starts to rise. It gets higher and higher and higher. And so that's why we can't just blow them down to a normal CO2 of 35 to 45. We have to go even lower, because the normal end-tidal CO2s that we see, or PaCO2s of 35 to 45, is predicated on a normal bicarb of 22 to 26. So as the bicarb shrinks, the CO2 has to shrink as well. Now, there's a calculation that looks at what the bicarb is and tells you what the CO2 should be to compensate for that low bicarb. And that's called Winter's correction. And essentially what you do is you have the expected PaCO2. And the way you get that is by taking the bicarb, multiplying it by 1.5, and then adding 8 to it. So if I walk in and I see that my patient's bicarb is 18, I go, all right, 18 times 1.5, I add 8, and that gives me 35. So that just means that I am trying to aim for a PaCO2 of 35. Well, what if I get the gases back and the PaCO2 is 55? Well, that means that the patient's not adequately compensating. I need to increase my minute volume. Now, what if the bicarb is 10? Same equation, 10 times 1.5 plus 8. There's always a plus or minus 1 or 2 in there as well, but I get 23. Now, if the patient was at 24, that's close enough. Like I said, there's a 1 or 2 variant in there that you can expect. But now I got to get the PaCO2 down to 23. That's quite a bit. But why? Well, something is taking up a lot of space on that anion column that's caused the bicarb to have to shrink down really low, which means I don't have as much bicarb to transport CO2. The body's not going to tolerate high levels of CO2 in its gas form, but it has to keep it in the gas form because it doesn't have bicarbonate to transport it. Well, what if you just gave them bicarbonate? Well, it can't have a higher amount of anions, so it's going to have to do the same thing and dissociate that, and now we just added more CO2. Now, when I get to this part of the talk, and I'm looking around, the critical care folks that do interfacility transport or have the ability to get labs, they have like an EPOC or ISTAT. They're like, oh yeah, that's really cool. That makes sense. The people who are running 911 are like, wow, that would be really useful if I had bedside blood gases. But I work in the back of an ambulance and I don't have that available to me. And so there's this concept of an estimated bicarb. And we use it quite a bit in the flight realm, I should say. I don't know, you probably use it in the ambulance as well. But in flight, I use this when I'm in the back of an ambulance. It's a scene flight. It could even be an interfacility, but usually it's a scene call. And I'm trying to ensure that my minute ventilation is going to at least hold them steady. It's not going to make them worse until I can get to the helicopter and get a gas, because we do have an EPOC. And so this estimated bicarb is essentially you looking at the patient's presentation and trying to guess where their bicarb is. And so if it's an oxygen perfusion issue, if you don't think it's any of the things that are increasing the anion gap, I guess is a good way of saying it, any of the weird stuff like DKA, propylene glycol ingestion, aspirin overdose, Tylenol overdose, metformin toxicity, if you don't think it's any of those things, and you think that maybe this person is just in a elevated lactic acidosis or lactic acidosis because they have an oxygenation or perfusion issue, then I estimate that their bicarb would probably be somewhere between 20 and 15, which means my goal, keep in mind, end-tidal CO2. So this is how much actually makes it out of the alveoli, through the tube, samples. This is your end-tidal, but this is a number that you have. I aim for an end-tidal CO2 of 30. If I think that there's a degree of a metabolic acidosis, then I'm aiming for 30. Now, if I am suspecting DKA, or I'm suspecting, I should say, that this patient has some weird ingestion, then that's going to take up more of that anion load. It's going to take up more space, which means that bicarb is probably going to be really low. For that patient, I aim for an end-tidal CO2 of 20. Now, keep in mind, this is just to make sure that I'm doing a hat tip and I'm thinking about it and I'm aware that the body needs a higher minute ventilation. This doesn't mean it's dialed in perfectly, but this is a rough goal until I can actually see what that bicarb is. And so when we talk about end-tidal CO2 and the relationship it has to PaCO2, it's interesting because if you ask which one is going to be higher, most people get this right. It's the PaCO2, right? Because the PaCO2 is actually what's in the blood. So I think of this as like the source, right? So think about the blood coming back to the lungs. It's carrying CO2. The CO2 makes it across the alveolar capillary membrane. It gets inside the alveoli. It has to go up through the airways. It comes out the endotracheal tube and gets sampled in the little side port. And so it's essentially, I think of the end-tidal CO2 as what makes it through. So the PaCO2 is the source. The end-tidal CO2 is what makes it through, and then you're sampling it. So it makes sense that the PaCO2 would be your higher number and that the end-tidal CO2 would just be, what gets through all of that stuff, and they don't necessarily always correlate. Your end-tidal CO2 is always going to be less than what your PaCO2 is. So if I say aim for an end-tidal CO2 of 20 until you know what the actual bicarbonate is or what the actual PaCO2 is as well, then you could have an end-tidal CO2 of 20 and have a PaCO2 of 40. You don't know. And the sicker the patients are, the wider that gap, but at least you're acknowledging it. I say like a hat tip to it. You're saying, I am aware I am going to try to blow them down to an end-tidal CO2 of 20. And that's not easy. That's very difficult, actually, especially once you switch to positive pressure ventilation. So let's talk about that. Let's talk about how you get somebody's end-tidal CO2 or PaCO2 down the smart way. And it's not just copying the rate that they were at before. You'll hear that a lot. That is a bad idea when it comes to positive pressure ventilation. So when it comes to the vent strategy, I guess the first thing we have to acknowledge is trying to calculate their ideal body weight. Now, this applies more for once you actually get them on a ventilator, but I promise it'll make sense even if you're using a BVM as we move on. So we have a male and a female here, and we have to calculate their ideal body weight, right? And so that's based off of how tall they are and their gender. So if you're 5 feet tall and you're a male, then your ideal body weight is 50 kilos. So if you're 5 feet tall and you're a guy, you're 50 kilos. Now, if you're a female, you start off at 45.5 kilos. So you could be 300 pounds, but if you're 5 feet tall, you're 50 kilos, right? Because the lungs don't get bigger if you stack on more fat around it. So the lungs stay the same size. Now, for every inch above 5 feet, then you can add on a 2.3 kilogram difference. So 2.3 kilograms for every inch above 5 feet. So the way I typically do this is, let's just say I have this guy here, and he is 5'11", and his name's Tyler, and he's very good looking. No, we'll say that 5'11". I'll start off with the inches, right? Because I already know I'm just going to add 50 kilos when I'm done. So 11, and I'll say, all right, what's 11 times 2.3? I get 25.3 kilos, and then I just add 50 to that. So my ideal body weight is 75.3 kilos. And you get roughly in that area. Some people don't use the 0.3, they just use 2. I think either way is fine. But for the lecture, I'm going to do the math the right way. Now, with that 75.3 kilos, we need to come up with a minute volume. And so if you look at the minute volume compensation that our body normally uses, essentially if you multiplied this by 100 mLs, you would get the minute volume. So and essentially what you're doing is just moving the decimal here. So for me, 7.5 liters per minute is what I'm probably moving right now, just on a regular basis. That's just my basal minute volume. Obviously, if I'm running and I'm creating lactic acid, it's going to go up. But otherwise, it's right around probably 7 to 8 liters per minute. Now, if I go into a metabolic acidosis, you're going to see that double. So it goes from 7.5 to 15.6. And so all I'm doing is just multiplying their ideal body weight. Instead of by 100, I do it by 200 now. Now, if you're in a severe metabolic acidosis, this is the patient that's doing the Kussmaul respirations, DKA, the bicarb is 5, then it triples. So ideal body weight times 300. And so I get 22.6 liters per minute. This is very, very difficult to do with positive pressure ventilation. You have to be very smart because minute ventilation is respiratory rate times tidal volume. So you could have low tidal volumes and really high rates and still hit this number, but that would be a bad move because you're not actually increasing the alveolar minute ventilation. The alveolar minute ventilation is the most important thing because that's how big your scoop is that you're scooping out that CO2. If you're just dead space breathing at 40 breaths per minute, that's not effective. You're not going to lower that CO2 burden. So what do? We start with volume first, somewhere around 8 cc's per kilo of that ideal body weight. Try to keep your inspiratory pressures lower, 30 or so. But if you have a patient that has a lot of transalveolar pressure, which is the pressure like on their chest, you may need higher pressures, and that's a priority in a metabolic acidosis. So volume first. We want to make up that minute volume with volume first. You don't want to sacrifice this 8 cc's per kilo. And then we increase rate second. But if you're increasing your rate and all of a sudden your exhale tidal volumes start to drop, you got to stop. You got to look at it and go, am I working smarter or harder here? Because volume is what is going to get that out. Alveolar minute ventilation, not just rate. And that's why when you hear paramedic instructors say, oh, copy the rate they were breathing at before they were intubated, if you try to do that on a mechanical ventilator, you're going to find that your 40 breaths per minute are equaling, 200 to 300 ml exhale tidal volumes, which is not going to help with that CO2 burden. And now the way that I use the rate, or the way I titrate the rate, is I use the flow waveform. And so I want to show you what I mean by that. So I use the Hamilton T1 vent. You can do this on any vent that you can see the flow waveform. If not, I'll show you kind of a hack, a workaround. So this is the pressure waveform right here. This is the flow waveform. So anything above this white baseline here is air going into the patient. And then this is air leaving the patient. So let's just walk through this, right? So the ventilator starts blowing air into the patient. So we can see we are increasing the pressure here. We see that flow rate increases. And then what happens is the vent goes, well, I don't want to go any higher than that, 30 of pressure you have or 20 of pressure, inspiratory pressure. So it starts to slow the flow down, right? So you can see the flow starts slowing down. And then when it gets to right here, it's doing nothing, right? So the air is already in the patient. It's not changing anything. The air is it's just sitting there. And then we allow that air to actually come out. And so then the air is able to release and they return to the baseline here. So if you look at this from a standpoint or a perspective of opportunities to increase the rate, right here, we're not doing anything. And right here, we're not doing anything, right? These are the two areas that we're not doing anything. So we could shave some time off of that, right? Because it's not cutting into our minute volume or our tidal volume at all. But if you start increasing the rate too much, what can end up happening is you see this inspiratory flow waveform start to change. So you see how this slowly comes down. This is not air leaving the patient. This is just the fan slowing down that's blowing the air into the lung. If you cut it too short, you're not going to get that air that should be blowing in there. So look at these two inspiratory flow waveforms. You see this one right here starts to come down and then it drops, right? What happened here? Well, it ran out of time. The I time was too short. So if you increase your rate, you're going to notice on the ventilator, your inspiratory and expiratory ratio is going to stay the same, but the actual time is going to change, right? So if you're a 1 to 2, 1 to 3, that's a ratio. And so the time is predicated on the actual rate. If the rate's too high, you're going to start cutting into your inspiratory time or your expiratory time. So on this one, if you increased the I time, you would get more volume. And so that's really important, because if I see this, I know that I'm starting to steal from volume, and volume is what is going to help me blow off that CO2 the most efficiently. Now, this one, you see how it comes up, it comes down, and it rides the baseline for a little bit. So if I looked at this and I was like, oh, I want to try to get more volume, increasing the I time is not going to get me any more volume, because I'm already coming to baseline. So if I increase the inspiratory time, all I'm going to do is ride this baseline out longer, but I'm not going to get any more volume. So when you look at this ventilator here, you can immediately lock in and see that I'm coming up, and then look at, see how I'm just dropping right down. And then I go into the expiratory phase. Look at all of this time at the expiratory phase that I'm sitting and doing nothing. That could be dedicated to the inspiratory time, and then I would see my volumes increase. Here's another one. So look at this one. So you can see they're getting 492 exhale tidal volume, 492 mLs. And then if I wanted to increase the rate, I can see I have a little space back here and a little space right here that I could increase that rate, and I could increase my minute volume. Now, if I start doing it and I see my exhale tidal volumes drop to 300, I probably added too much rate and it started cutting into those. Now, something else you can do when because you won't have a respiratory rate of 14, 15. It's going to be high, but you're doing that and increasing it until it starts to cut into your exhale tidal volumes. And then you may look at it and be like, well, you know what, like I'm exhaling fine. It's the inspiratory side that needs a little bit more love. And so maybe you take your 1 to 2 ratio and turn it into a 1 to 1 ratio. So that way you're giving a little bit more to the inspiratory side. When you have a patient that you get the minute volumes up to like 20 liters a minute, like you will need in some severe DKA or metabolic acidosis, you're going to find that you really don't need much PEEP at all. You can almost do like a controlled air trapping, which, PEEP is just controlled air trapping. Check out this video I did. All right, so we are acting like we got a patient with a severe metabolic acidosis, and you can see that the flow waveform is not returning to baseline, and you'd be like, oh man, like this patient's air trapping. We got to try to extend that exhalation time. However, if you look at it, you can see that when we stop exhaling and we go into the inspiratory phase, if you go up here to the pressure, you can see that only equates to about 1.8 of PEEP, where you wouldn't even think twice about having somebody at 5 of PEEP or whatever. So we actually turn the PEEP off, and we're giving PEEP by just setting the exhalation time shorter. So because you're spending such a short time in between breaths, you can get away with turning that PEEP down. It'll give you a little bit more of a delta, a difference, and so you can see it easier to hit tidal volumes with reasonable and safer pressures. All right. Well, that was a lot of information, but that's my approach to the intubated patient with a metabolic acidosis. This is me, the little clinician, looking at was his Bowser or something. It can seem like a very intimidating task, but if you have a plan, you understand electrical neutrality and why the bicarb's shrinking, and how because that bicarb shrank and the body has now all this dissolved gas CO2, it wants to transport it as bicarb, but it can't because it doesn't have bicarb. And if you give them bicarb, they're just going to get rid of it again because you need to get rid of whatever's causing that acidosis. All right, guys, thank you so much. I hope the rest of the conference is great for you. And this is ventilation, metabolic acidosis, playing defense.